Hey guys, back with the second part of the video, and I realized that I left another thing out that's kind of important as far as axis deviation. In addition to some of the physical things that can shift the axis deviation, another thing that can alter it significantly is a past myocardial infarction. So we'll draw our little heart here, and this is of course right atrium, right ventricle, left atrium. Now, remember that my axis is normally going to be in this kind of direction. But let's say that a year ago I had a massive lateral wall MI. So what happens during the MI is the cells become ischemic, and as they start to die, they lose their ability to conduct electricity. And eventually this will all get replaced with scar tissue, which can't conduct electricity. So depending on the size of the area that's involved, when that electrical signal comes through, this doesn't transmit any of it. So I'll get a shift. There'll be less activity on this side of the heart than there used to be, which will end up shifting the axis away from the infarction. So if I had an infarction on the right side, it would shift the axis further to the left. If I had one on the left, it would shift the axis further to the right after it healed, or even during the acute phase. We'll talk about Q waves a little bit later. This is involved in why people develop Q waves in MIs, but we'll cover that in a few minutes. I wanted to start first with basically some quick rhythms and recognition. So we're going to go back to the PowerPoint and go over a few key numbers to know. There's not a lot of them, surprisingly. Two of the biggest ones are 100 and 60. So just know that any rate that's over 100 beats per minute is considered a tachycardia. Any rate that is less than 60 beats per minute is considered a bradycardia. And they may not always be in the title of the rhythm, but usually they are. You can have a junctional escape rhythm, which by definition is bradycardic. It'll be less than 60 beats a minute. Or you can have atrial fibrillation with rapid ventricular response, which will be over 100, which is a tachycardia. So just because it doesn't say tachycardia or bradycardia in the name, just know that if it's over 100, it's too fast. If it's under 60, it's too slow. Another important number, PR interval, 0.12 to 0.20 seconds. Just burn this into your brain, burn these into your brain, and also know your QRS complex should be less than 0.12 seconds. Now, there is some variation in different books, and you'll get into this more next year. If your QRS is wider than 0.10, which is 2.5 of the little tiny blocks, you have to look at the possibility of a hemifascicular block. But don't worry about that now. For now, just remember this. So the number 3 becomes really important. If your heart rate is over 100 beats a minute, the distance from R wave to R wave will be less than 3 of the big boxes, the 5 millimeter by 5 millimeter boxes. And then your PR interval should be between 3 and 5 of the little tiny boxes. And your QRS should be less than 3 of the little boxes. So, quick review of normal, rounded P wave, flat PR segment. PR interval should be that normal distance of 0.12 to 0.20 seconds. QRS complex, remember a Q is not always seen. It's only a big deal if there's a significant Q wave, and we'll talk more about that later, but a lot of times you won't even see a Q wave at all. It'll just be an R or an S, depending on the lead. Sometimes it may be more negatively deflected. Then a flat ST segment that stays on the isoelectric line. And that isoelectric line is what there would be if there was no electrical activity. So it's just this normal level without any electrical change. So your PR segment and your ST segment, and then also the distance from your T to the next P wave, are all on what's called that isoelectric line. And that's going to be normal. So, like we talked about in the last video, if you can understand those pretty well, the more you see them, the more familiar you'll get with them, and then the things that are abnormal will really start to jump out at you. So, when it gets to rhythm interpretation, I highly recommend you develop a system and stick to it. There's several different ways out there. The Dubin book that you have to read over the summer will get into their technique for how to interpret them. Most of them are pretty similar, but it's important to be consistent so that you don't miss things and make mistakes. One of the first things that I look at when I look at an EKG is the rate. So you want to look if it's too fast, too slow, or too weird. So like I said, if you can identify normal, then abnormal stands out. Try to figure out what's abnormal about it if it's weird. Your R to R interval is your big go-to for your rate. So your R to R interval is essentially from the peak of one R wave to the peak of the next R wave. So if it's closer than 3 of these big boxes together, it's over 100. There's actually a nice little mathematical formula, or not even a formula, just numbers that you should know. This is another one to kind of always remember. But if you can remember the 3 to 5 boxes, that'll help narrow it down very quickly. But if they're only 5 millimeters apart, like if there was another R wave right here, my heart rate would be 300. If the next one was here and it was 10 millimeters apart, it would be 150, 100, 75, 60, and I forget what the next one is down. But that's just going to be a standard on every EKG that you see. So if it's between 3 and 5 boxes, it's a normal rate. Now, sometimes things just start to look weird. So if you start asking yourself, well, what is weird about this? After you figure out the rate, then let's figure out the things that are wrong. So you want to look for regularity, widening the QRS, unusual or absent P waves, extra P waves, or if your PR intervals are wrong. Now, we're not going to run through all of the different rhythms that are on here, just the ones that were covered in your physiology class, which should be normal sinus rhythm, sinus tach, sinus bradycardia. We'll go over the atrioventricular blocks, ectopic beats, and then ventricular tachycardia and ventricular fibrillation. And I think by the end of these, you should have a pretty good system to be able to identify them. A lot of this is pattern recognition, and the more you look at, the better you'll get. I'll post some websites that have some good EKG material on Facebook too, if you guys want to do some practice with them. So one of the first things is regularity, and there's a reason it's called a heart rhythm. It should be a steady, consistent pace. If there's pauses or skips or changes in speed, those are not regular. So it's not always a big problem if it's irregular, but you want to see if things are regularly irregular or irregularly irregular. And that's kind of a mouthful to say, but if it's something that's a repeating pattern, like say it's missing every 3rd beat or every 4th beat, and that pattern repeats itself again and again, that's regularly irregular. You know it's irregular, but it's predictably irregular. If it's just this random assortment of stuff and there doesn't seem to be any order to the rhythm, then you would say that's irregularly irregular. So just as an example, you look at this right away. If you ask too fast, too slow, too weird, you're going to come up with too weird. Hopefully, you will notice that this doesn't look right. So I look for what does look right. Well, here I have a P wave and a PR interval and a narrow QRS and what looks like a T wave. And then this looks, oops. This just looks like a great big mess. But then I have another one that looks normal here and another one that looks normal here. But these are definitely weird. But it's repeating. I have a normal one, a weird one, a normal one, a weird one, a normal one, a weird one. So I would say that is regularly irregular. This would be an example of something that's irregularly irregular. You can see it's a little harder to spot at first, but none of these R to R intervals are exactly the same. Now, if I had a nice regular rhythm, the distance between R wave to R wave should be consistent from one to the next, to the next, to the next. Sometimes if it's hard to tell, what you can actually do is put a piece of paper up over the EKG and take a pen and mark the very tip of 2 of the R waves or even 3 of the R waves. And then slide your piece of paper down and see if they keep meeting up. If they don't keep lining up with all the rest of them, it's irregular. Sometimes it can be very subtle. Then you want to look at your QRS. Is it normal? Is it less than 0.12 seconds in width, or 3 of those little boxes in width? or is it too wide? All right, now if we go back to our conventional electrical pathway, if it follows this signal right here, it should take it less than 0.12 seconds to complete that. If it deviates from this path, say that I have a block here in this bundle branch, and then it has to kind of go around it. It's going to take longer to depolarize everything this way because it doesn't come through this fast conduction system. Then I'm going to get a widened QRS. There's other reasons I can get a widened QRS as well, but if I see one that's wide, I know it's not following the regular pathway. Then you want to look to see if there's P waves. If yes, are they normal and are they upright? So here you can see I have nice normal upright P waves. I want that PR interval, which is the start of this P to the start of the QRS complex, to be less than 0.2 seconds, which should be 5 millimeters. So it's definitely less. So it's normal, it's upright. Here I don't even see P waves. And here I have P waves, but they're upside down. And we'll talk about why that can happen in a little bit. But that should jump out at you, either that they're absent or that they're inverted. And then another thing that's very important is, do I have one P wave for every QRS complex? So look for your P waves first. I have a P wave here, here, and here. I find those. After each one, do I have a QRS complex? That tells me that that beat is starting somewhere up here and each one is making it through. Versus if you look here, I have a P wave and my P waves are nice and regular. I can't see this one here because it's kind of buried in this T wave. If you look at the difference between this T wave and this T wave and this one, you can see the shape is different because I would expect another P wave to be right here falling on it. And that happens sometimes. They'll get hidden within the QRS or hidden on top of a T wave. But I have a serious problem because I have an impulse that's starting here, but then it's not being carried the rest of the way through the heart. So I need to figure out, are all of these being conducted, or are these coming from one of my backup systems in the event of say a 3rd degree AV block. Then the last thing you really want to check is your PR interval. I want to make sure it's not too long or not too short. So here you can see it's nice and normal, and here you can see it's very extended. But I still have one QRS that's nice and narrow and upright for every P wave. So we'll skip over why you can have a shortened PR interval. You guys don't need to know that yet. So we're going to start with normal sinus rhythms. Or start with what's most normal, which is a sinus rhythm. A normal sinus rhythm is not a bradycardia, not a tachycardia. It originates in the SA node, gets conducted normally through the rest of the heart, and has a rate between 60 and 100. So you're going to see some sort of variation at this. So look at it real quick, answer the questions. Is it too fast or too slow? Let's see, am I more than 5 boxes apart? 1, 2, 3, 4. I'm in between 3 and 5, so my rate is normal. Does it look too weird? I don't see anything that jumps out at me that looks weird. Is it regular? If I march these out, my R to R interval is consistent the whole way through. So it's nice and regular. QRS is narrow. P waves are present and upright. And I have one P wave for every QRS complex. And no changes in my PR interval. It's still between 0.12 and 0.2 seconds. That is a normal sinus rhythm all the time, every time. Now, the next thing that can happen is, let's say this is your normal rhythm. You get up and you go jogging. Your autonomic nervous system will kick in to increase your cardiac output, and your heart rate is going to go up. So once it gets over 100 beats per minute, you're going to go into what's called sinus tachycardia. That still means that it's originating from the SA node, coming down normally through the atria, still has a delay through the AV node, and gets conducted normally through the ventricles. So everything looks the same, it's just faster. Now, one of the problems with this is when the rate starts to get very fast, you can see in this bottom one here, the P waves are happening at the tail end of the T wave. So it's a little bit subtle at first, and your eye may not pick them up right away. But the more of them you see, you'll be able to find that. If that was pushed back just a little farther, you'd have a very hard time differentiating what it is. And they would usually probably try something pharmacologically to intervene because you're getting into considerably high heart rate. You'd be over 150 at that point. But in the one on top, you can definitely see a delineation between the T wave and the P wave a lot better. But my R to R is interval, or my R to R interval is normal. So it is too fast. It's not really too weird. It's regular. My QRSs are narrow. P waves are present and upright. I have a 1-to-1 P to QRS ratio, and my PR interval looks pretty normal. I can't 100% see the beginning, but the P wave doesn't take that long. So I don't think it's stretched all the way out back to here. It should be pretty normal. So I can assume that this is sinus tachycardia. Now the opposite can happen. Let's say you go to sleep, or if you're someone who is a runner or a cyclist who's in incredible shape cardiovascularly, a lot of those people have a resting heart rate well below 60. I know Lance Armstrong supposedly had a resting heart rate in the high 20s when he was sleeping. Doesn't mean anything is wrong with him. He's just in better shape than you or I. So it's still the same thing. It's just much slower, but only from one heartbeat to the next. It doesn't affect anything within each conduction cycle of the heart. It is too slow. It's not really too weird. It's regular. QRS is narrow. P waves are present and upright. 1-to-1 P waves to QRSs, and a normal PR interval. It's a sinus bradycardia. So that's pretty much it for the sinus rhythms. There's a couple other ones that are in the PowerPoint, but ignore those for right now. I want to talk about blocks. And now heart degree blocks are one that tends to give people fits. I don't know that it's ever explained particularly well. I don't even know that I can do that good a job, but I'll give it a shot. So a heart block by itself is not a rhythm. You have an underlying rhythm, and then a block is just a problem with the conduction. Usually it's through the AV node. The ones that occur through the AV node are labeled first, second, and third degree blocks. Just like burns to your skin, third degree is worse than first. Okay, they can happen in any rhythm that's generated above the AV node. So your patient will have an underlying rhythm, like they'll have a sinus bradycardia with a first degree AV block. Now there are other blocks that can occur further down. You can have bundle branch blocks within the ventricles, and those are different, and you don't even need to get into those now. But we'll go back to our conducting system here. Now you remember there's that delay as the signal passes through the AV node. Think of this like a construction zone in traffic. All the cars are coming in, they all have to slow down, but then they all get through. That's the way it should normally work. In your AV conduction blocks, you have a progressive series of problems. So in a first degree block, everyone still gets through, it just takes them a lot longer than normal. So if you remember which phase of that electrocardiogram this corresponds to, which should be my PR segment, if everyone is still getting through and it just takes them longer to get through here, that's going to be reflected by a longer PR segment, which is going to increase my PR interval. Remember, we measure by PR interval, not segment. So this will be longer than 0.2 seconds, which means it'll be longer than 5 of those little boxes. So if we go back to our PowerPoint on the first degree block here, and if you look here, this one starts maybe just a millimeter before this darker 5 millimeter box line. And if you go over 5 more millimeters, we're already in the second half of the P wave. So this PR interval is clearly much longer than 0.2 seconds. But if we run through our regular things, is it too fast, too slow, too weird? Let's look. We're 1, 2, 3, 4. It's not too slow. It doesn't really look too weird. It jumps out that the PR interval might be a little bit too long. But I have P waves. They're upright. I have narrow QRSs. I have 1 P wave for every QRS complex. But my PR interval is very long. So I have a sinus rhythm with a first degree atrioventricular block. Everything else about the rhythm is the same as a sinus rhythm. It's just taking longer to get through the AV node. Now, the next worst block is a second degree block. And to make it more complicated, there's actually 2 types. There's a second degree type 1 and a second degree type 2. You'll hear them called by different names. You'll hear them called Mobitz 1 or Mobitz 2. or second degree type 1, second degree type 2. And also the name for a second degree type 1 is called a Winky Bach. Don't ask me why, it just is. So a key feature that you'll find with second degree blocks is that the P to P interval will always be the same. So you know how earlier we measured our R to R interval with the distance from R wave to R wave? You can also measure the distance from the peak of your P wave to the peak of the next P wave. So since the problem lies in the AV node, not the sinus node is still going to fire at this regular rate and regular rhythm. The problem is how they're being conducted through. So the first one that you can have is a type 1. And this one can be kind of subtle to catch, but one of the first things that should jump out, in both second degree blocks, you have some beats get through the AV node and some beats don't. And there's a slight difference in how those two manifest. So in a type 1, you basically have where the PR interval gradually gets a little bit longer and a little bit longer, and then it will eventually miss a beat. And it's usually a repeating pattern. It'll usually drop every third beat, or every fourth beat, every fifth beat, every third beat, but something over and over again. I like to compare this to two people jogging. One's a great athlete and the other one's fat and out of shape. And the one that's fat and out of shape just starts lagging behind and lagging behind and lagging behind, and then just has to stop and take a break for a second. And then it catches back up, lags behind again. But it should be in a repeating pattern. It won't always be consistent. It might drop a fourth beat 5 times in a row, then a fifth, and then go back to 4 several times in a row. But you'll be able to see that lengthening of the PR interval. So you can run through all these and take a look at it. But it should jump out at you that there's something missing. Now, the next one is a second degree type 2. And a second degree type 2, usually your PR interval is fine, but it's just that some of them get through the AV node and some of them don't. Now this can be in a repeating pattern or it can be in a random pattern. It's usually fairly consistent, but not always. So you can see in this strip, too fast, too slow, too weird. Rate, when I look at the beats that are being normally conducted without problems, the rate isn't too bad. Overall with the whole strip, though, I may not be having a very good pulse rate per minute, depending on how many beats I'm dropping and what the underlying rate is of the beats that are going through is. Is it too weird? Yes, there's something that jumps out to me. This looks very abnormal. So is it regular? Well, these are regular. This is not irregular. So I would still say it's kind of irregularly irregular. But my QRS is narrow and upright. I do have P waves. They're upright. But I don't have a P wave for every QRS. Right away, that should tell you you have a block, either a second degree or a third degree block. If you have more P waves than QRSs, there is a problem through the AV node. So I just have to look and see what the problem is. So this P wave seems related to this QRS. These all look good. So I can assume that this one's not going through, this one's not going through, these are going through fine, this one's not going through. Now, the next heart block that you can have is a third degree block. And for some reason, this seems to be the most puzzling to a lot of people. It can be a little hard to distinguish at first, but you have to think of it as two different things. So your sinus node doesn't know that the AV node is messed up. So your sinus node is going to keep firing at its normal rate, probably somewhere between 60 and 100 beats per minute. But that signal doesn't go through anywhere. So at this point, you have essentially your backup quarterback, which is either going to be your AV node or your third string guy down in the bundle of His or the Purkinje fibers, who's going to be waiting for a signal, and after a while and no signal comes, it's going to fire on its own. So you basically have two separate heart rhythms going on at the same time. You're going to have a faster SA rhythm that you'll see by measuring out your P to P interval, and then you'll have a slower R to R interval, but they'll be completely out of sync with each other. Now, sometimes they can overlap. I like to make the analogy, if you've ever been sitting in traffic in the rain and watched your windshield wipers, and maybe the windshield wipers in the car in front of you, every once in a while it'll seem like maybe they're in sync for a little while and then they get off sync, or turn signals will do the same thing when you're waiting at traffic lights. So there may be periods where they overlap and look like they're related, but over a longer stretch, you'll see that they're not. So you have these two independent rates. Usually the escape rhythm will be bradycardic. Not always. The other thing that can make these confusing is sometimes, depending on where the escape beat comes from, it can either have a narrow QRS or a wide QRS. But the biggest trait is you have a consistent P to P interval and a consistent R to R interval, but with different rates. So it can be a little tricky at first to see. But here's two different ones here. Now we'll start with the top one. You look at it at first glance, is it too fast or too slow? It might be a little bit too slow. It's definitely too slow. Is it too weird? Yes, it looks pretty weird. So I look at my P waves. I do have P waves. My QRS is narrow and upright, but I don't have a P wave for every QRS. So if you can see here in the red arrows, they've marched out the interval from P wave to P wave to P wave to P wave. I have this nice regular rate that my SA node is firing at, which is actually kind of fast. It's a little over 100 beats a minute. But my ventricular response is much slower. Now, if we go back to our conduction map here, so these blocks can occur high or low in the AV node, even down in the bundle of His sometimes. Now, the problem can be where the backup comes in. If I have a block that's higher up in the AV node, like say my complete blockage occurs right through here, and somewhere in my bundle of His right here decides to take over, my conduction through the ventricles is going to be almost the same as it would have been had the impulse come through normally. So I will get a nice narrow QRS complex as it goes through the ventricles. If it's not firing until later, say it fires down here in one of the right bundle or the right bundle or the left bundle, then that's going to seriously alter the conduction. It's going to spread this way and up and around and then gradually over this way. It's going to take a lot longer to depolarize the entire heart. And since this is a measurement of time, my depolarization of the ventricles is going to be wider and usually shaped abnormally. So you can see this one right here looks very different from the other QRSs in there. And if you were to measure out, it's a little bit too wide. So this is probably somewhere else in the heart that got tired of waiting for an impulse and fired on its own, since this rate is pretty slow. This one is a little trickier to see. At first glance, it might seem kind of normal. But then you look through and you start seeing that your P waves are... You shouldn't have a P wave right after a QRS. You start to see I have this nice regular rhythm of P to P intervals and a nice regular rhythm of R to R intervals, but they're at two completely different rates. So that should automatically tell you third degree heart block. I'll post some websites that have some good tutorials at recognizing blocks. This is usually one of the trickier things for people. If you're doing good with this, you're doing great. Another thing that can get people is ectopic beats. And all ectopic means is extra. Now, normally they're premature. You just have to try to differentiate to make sure that they are not escape beats. In other words, that you have a block and no signals coming, and one, like your third string quarterback is trying to take over to keep you alive. Usually what happens is you get ischemia somewhere in the heart, and one of those sites along the pathway will fire earlier than it is supposed to, and it'll start the chain reaction and send an impulse down an irregular pathway through the heart. And it can come from anywhere along that pathway, and actually it can come from even any of the muscle cells, if they become ischemic enough, can develop electrical problems, and they can spontaneously start an action potential, and that ripple effect will start from whatever cell it is that begins to start this chain reaction. So two terms that they use are unifocal and multifocal. Unifocal means it's coming from the same spot. So if you have one small area of the heart that's become ischemic or irritated and is consistently firing, all the QRSs coming from that point will look the same. If you have QRSs that look bizarrely different from each other, then they're probably coming from very different places of origin. So, like I said, they can come from anywhere. So here, if I look at this one, you can see I have a pretty good rhythm. It looks pretty slow, actually, but that can be normal for some people. So I would say this is a sinus bradycardia. I have an upright P wave, normal QRS, one P wave for every QRS. All of this looks pretty good, even though it's kind of slow. The odd man out in this situation is this beat right here. Now you can see that the QRS looks exactly the same as all the other QRSs. So it has to be following the same pathway as the rest of these. What I don't have is a P wave for this one. So what that tells me is I have a sinus bradycardia with a premature junctional contraction. Now junctional means that it's coming from the AV node. So depending on where in the AV node it comes through, there's a mechanism to block retrograde conduction so that it won't conduct from here and backwards through the atria. But if it's high enough in the AV node, it can actually do that. And sometimes that'll give you an upside down P wave. But since this is probably coming from lower, I don't have any P wave at all. I just have my normally conducted QRS complex. This one's a little tricky, so we'll go to another one. So here, your eye should spot pretty quickly. This one looks like it's coming early, and this one looks like it's coming early. And one of the big things that I noticed right away that's different is, look at my P waves. I have a P wave here that's nice and round, one here that's nice and round, one that looks like a TP that doesn't look like the others. And on the other earlier one, I have one that's a TP that doesn't look like the others. So what can cause that? I probably have an irritable cell somewhere else in the atria that's firing, and it changes that vector. So, but after it's triggered in the atria, it goes through the AV node and the rest of the conduction is normal. But I can tell that it's coming earlier than expected because everything else in that heartbeat looks the same as the normally conducted beats, and it's only my P wave that's different. I can tell that that's an atrial, that complex is of atrial origin. So I would call this a sinus rhythm with a premature atrial contraction, and actually with two of them. And because they look identical, I would say that they are unifocal. Usually no one cares about unifocal unless you're talking about ventricular problems, because that can put people into dysrhythmias very quickly if they're having multifocal PVCs. So here's a little explanation of that. Now here we have, and these should jump out at you immediately as to what is weird, is this one and this one. So we'll get to these in a second. Let's look at our underlying rhythm. So I have a pretty good run here of 4 beats. They're more than 3 squares apart, less than 5, so I know I have a normal rate. I'm not too fast, I'm not too slow. I have P waves for every one. They're normal and upright. I have narrow QRS complexes, good upright T waves, 1 P wave for every QRS complex. Now, does this look like it's coming early or late? In other words, am I anticipating this next heartbeat to have already started by here? I'm not. If I walked out my R to R interval, I would expect my next R wave to be around here, but this is coming early. So I know it's a premature beat. It's not an escape beat due to a slow rhythm. Now I have to look at it. Does it have a P wave? No, it does not. Does it have a QRS that looks like the other QRSs? No. But I do have basically an RS here with no P wave, and it's very, very wide. So this tells me that this is coming from somewhere in the ventricle. So this is a premature ventricular contraction. And since this one looks exactly the same as this one, I would say these are unifocal PVCs. In other words, I have one site somewhere down here in the ventricle that's becoming ischemic, that's starting the signal going this way. Pretend this was lead 2, and you can see that it's going, my deflection is much more negative, so most of my energy is going towards the negative electrode. So it's probably starting from somewhere lower down here in the ventricle. Now this one is similar, but has multifocal PVC. So right away, this should jump out as weird, and this should jump out as weird. But looking at my underlying rhythm, they're in between 3 and 5 boxes apart, so my rate's normal. I have P waves, narrow QRSs. All this looks like normal sinus rhythm. Then this comes early. This one also comes early. But there are 2 completely different morphologies, which means different appearances. So these are not coming from the same place in the heart. The fact that this one is so positive and this one is so negative tells me they're coming from 2 very different areas in the ventricles. which signifies a bigger problem. It means I have more ischemia going on. So this is a much more serious, or potentially much more serious problem than the unifocal PVCs. We used to joke on the ambulance that if you were over 70, you were allowed to have at least 3 or 4 unifocal PVCs a minute. It's very common. This signifies usually a much worse problem. Okay, now sometimes these can come in groups where they get called couplets or triplets, where you get 2 or 3 in a row. If you get more than that many in a row, though, it's considered a rhythm change. So that's pretty much it for the ectopic beats. And then the only other two that you really need to know are going to be ventricular tachycardia and ventricular fibrillation. So let me see if I can find those here. So this is ventricular tachycardia. Now, you can have this with a pulse or without a pulse. You'll figure out more of that later. What you're going to see is you will have some sort of organized activity. Ventricular tach is, by nature, always fast. It's a tachycardia, so it's going to be a rate over 100. Typically, you'll see it in rates around 170 to 180. You won't see it very, very often, but in a lot of people, depending on where it is in the ventricle, if it's producing adequate compression of the heart, they can still maintain a decent blood pressure and pulse for some time. I've had lots of patients who are awake and talking and complaining of chest pain who are in VTAC. What you'll notice is you'll have wide QRS complexes, no P waves, and it's very fast. But there's some consistent organization to it. It's this big sort of sawtoothy pattern that runs all the way through. Now, the morphology can change dramatically from one patient to another depending on where in their heart is irritated and starting this beat. But these are just 3 different examples of VTAC. You can see they all look a little different from each other, but when you run through those questions, there's not really anything else that could be doing that. And then the other one, this is one of the easiest ones to recognize. This is ventricular fibrillation. This is the one that everybody yells clear for and shocks people. What basically happens in ventricular fibrillation is you have multiple sites in the ventricles that are ischemic and start firing early. And they can fire, if one fires here and around the same time one fires here and another one fires here, you're going to get these waves that intersect with each other, and they have to repolarize. So instead of getting an organized compression from apex to base of the ventricles, it just basically sits here and quivers. You lose any organized contraction within the heart. It just starts fibrillating, which this is a pulseless rhythm. This is not a rhythm that's compatible with life. You will not sustain this for any length of time. People usually go almost immediately unconscious because they stop flowing blood to their brain. Now, it can be in 2 ways. You can see what's called a coarse VFib, which is like this, where there's still probably a lot of electrical activity within the cells. It's still not compressing very well. But once your heart stops beating, you also stop perfusing blood to your heart, and this electrical activity is going to start to slow down, and you'll get into a fine VFib, which will be just some minimal fluctuations in activity, and this will eventually just dwindle right down into asystole, and they'll die. But it's not too fast or too slow. There's no organized rhythm. It's definitely weird, definitely not regular. No QRSs, no P waves, no PR interval or anything. Squiggly, ugly, nasty rhythm. This one can be a little trickier. Sometimes people confuse it with asystole. Sometimes this can get confused with ventricular tachycardia by people. But ventricular tach should be a repeating motion like these, not this squiggly, ugly line like VFib. So that's pretty much it for the rhythms. Run back through it if you have any problems. I'll post some things on Facebook to some good websites where you can practice them. The more you see, the easier they become. But if you can kind of get this system down to run through just these few little checkpoints, you should easily be able to tell what rhythm it is. And that'll help you in cardiology a lot for next year as well. So the last thing I want to get into, close that out, is Q wave progression, or MI progression. And that was a big point that Dr. Fitzovich wanted you guys to know. So when someone has an MI, there's not all heart attacks will be what's called a STEMI, which stands for ST elevation MI. But a lot of them will, and it's a hallmark that they used to look for in 12-lead EKGs to determine if someone is having a heart attack. They still follow it up with cardiac enzymes just to make sure, but if you see these, it's pretty indicative. So there's a set group of changes that commonly occur in people when they're having a heart attack. So this is more of a normal QRS complex over here. This one does show a Q wave. Like I told you before, not everyone will show a Q wave. And you can have an incidental Q wave that is perfectly healthy. If you look down here, this is considered a pathologic Q wave. And there's a set of criteria. It has to be more than 2 millimeters deep, more than 1 millimeter wide, and more than 25% of the height of the QRS complex to be considered a pathologic Q wave. So this is nothing. This is getting worse. This is a problem. And I'll explain why those Q waves occur in just a minute. But Q wave is not usually the earliest indicator of an MI. One of the most common things that you'll start to see is ST segment elevation. So here is where I would normally have my ST segment. As the heart becomes ischemic, sometimes that ST segment will get depressed, and that's usually where it's below the isoelectric line, and that's usually a sign of ischemia is ST depression. But ST elevation is usually a sign of infarction. So here you can see I have my P wave, my QRS, but my S doesn't even come all the way back down to my isoelectric line, and my ST segment is starting up here. So this is very significant ST elevation. This is commonly referred to as tombstoning, which is a very poor prognosis. It means you're having a massive MI if you're having ST elevations that high. They can be as low as 2 to 3 millimeters above the isoelectric line. It can be significant, depending on which leads you're looking in and which leads you see them in. But just be aware, they're not always this high. But that should jump out at you that this ST segment is way up here. As the MI continues to progress, you will eventually, or can eventually, start to develop a Q wave. And the Q wave is a deepening here, is a strong downward deflection. Like I said, it's got to be more than 1 millimeter wide, more than 2 millimeters in height, and more than 25% of the QRS complex in height, which this one clearly is. The other thing that will start to happen as the MI progresses is you'll get T wave inversion. This is usually a transient thing that will occur in people, and after they heal from the MI, this will tend to resolve. So will the ST elevation. But the Q wave, once it pathologically occurs, will always be there. It's a marker of loss of electrical conduction of the heart. So this is the three that are in the acute phase. And then as the MI starts to resolve, the T wave will remain inverted, the ST segment will start to come back down, and the Q wave stays put. And then as that gets a little better, the ST segment will normalize. Like I said, the Q wave, once it's there, is staying there. The T wave will stay inverted for a while, and that's usually the last thing to clear up. And eventually you'll go back to having a normal upright T wave. But the Q will remain. Another thing too, if you're looking at these on EKGs for anything, you always want to base it on a normally conducted beat. So let's say we had, trying to find one of my escape beats here. So you might look at this PVC and go, oh, that ST segment is elevated. You cannot use ectopic beats to determine that. You have to look at your normally conducted beats. These are different. Since this was conducted bizarrely or abnormally through the heart, it depolarized abnormally, it's going to repolarize abnormally. So these kind of get thrown out the window when you're looking at ST elevation to determine infarction. So don't look at these. You can't look at this whole strip and go, oh, there's ST elevation here and here, so they must be having a heart attack. There's no ST elevation in any of these. These are just kind of oddballs that don't count towards making that diagnosis. So you have to look at a normally conducted QRS to look for these types of things. Now, another thing that I talked about at the beginning where an MI can kind of shift over your cardiac axis. So part of the reason for, let's say we had a huge infarct over here. So I had a big infarct on my inferior wall. Actually, you know what? We'll change that. We'll make it an anterior or lateral wall MI. And let's say we're going to look at this through lead 1. So our lead 1 is negative here and positive over here. Now normally when the heart depolarizes, I'd have my SA node, my AV node. It's going to come down through the septum and then split into my bundle branches. Well, the septum actually depolarizes from right to left. So now that I have this area here of scar tissue that's healed from, say, an old MI, or even an active MI, this area has become ischemic and the cells have started to die, and it loses its ability to conduct electricity. Well, then it doesn't carry any kind of charge in a resting state. It becomes completely neutral. And even once it's old scar tissue, it behaves the same way. So this kind of acts like a window through the lateral wall that I can see. So when this impulse comes down and starts to depolarize the septum and I have energy going this way, normally that would be obscured by this here because of its resting potential. But that'll be transmitted through. So I may see a little bit of an elevation in this. Now if I'm looking at it through a different lead, that can give me a downward elevation when it first starts. And that's where I will get that pathological Q wave. So it varies depending on where it is in the heart and which lead you're looking through it at. But that's basically the nature of Q waves. And that's hopefully a little more helpful in understanding why those occur. Again, in some normal leads you may see a little tiny one, but if you see a pathological one, it's indicative of an area that's lost its membrane potential and doesn't conduct electricity anymore. So it just works like a little window where you can see through into the septal wall. That's pretty much it, I think. If you guys are doing okay with this, I think you'll be set for your next exam. And like I said, let me know if you have any questions. I'll be happy to help you guys out. Bye.